Okay, fantastic. Thank you for the introduction, Laura, and thank you for always including myself and our psychology team in CPAN's efforts. We are thankful to be included. As she mentioned, I'm Haley Ross-Young, and I'm an assistant professor in medicine here at the University of Texas at Tyler Health Science Center, as well as the director of inpatient psychology services. Just a little brief background about me. My training was at Baylor University in Waco, Texas, before I moved to Houston and did my predoctoral internship and postdoctoral fellowship with UT Health in Houston, specifically at Harris County Psychiatric Center. So I'm thrilled to be here to speak with you all today about distinguishing between PTSD and psychosis in children and teens. I have no financial conflicts of interest or other disclosures to report, and all opinions provided in this presentation are reflective of my own opinions. My learning objectives are kind of posted here, but briefly, my goals for this presentation are that folks who attend will be able to better identify the specific diagnostic criteria for both post-traumatic stress disorder, referred to as PTSD throughout this presentation, and schizophrenia. We'll also develop a better understanding of the prevalence rates of PTSD and childhood onset schizophrenia specifically. We'll be able to identify some appropriate screening measures and practices that are appropriate for medical settings and primary care settings. And we'll also become more familiar with the available evidence-based interventions for both PTSD and psychosis in children, as well as ability to sort of know when it's appropriate to make a referral for these services and what types of services to refer for. So first, I want to start off with our quote here. When you hear hoofbeats, look for horses, not zebras, which is credited to an unknown source. And I wanted to kind of open up our time together by just asking briefly, when you hear this quote, what do you think that it means? And you are welcome to unmute yourself and respond or throw your response in the chat box. What do you think it means? When you hear hoofbeats, look for horses, not zebras.
I think, sorry, David here. I was thinking that to me, it means when you're presented with an unusual, like something out of the usual, like, hey, you hear hoofbeats outside your window, like what's the most likely thing it could be first, and kind of triage your differential based on what's most likely and move down to least likely.
Yes, excellent. Thank you, Dr. Pollard. And I see that Laura and Dr. Johnson also include in the comments, consider what might be most common or the most likely reason. Excellent. Yes. So when we hear those hoofbeats, when we see a patient sitting in front of us, who is describing certain symptoms, we want to start by thinking about what is the most likely cause for these symptoms that a patient is reporting. And then, as you said, Dr. Pollard, sort of work down the list to the least likely. If the most likely reason doesn't fulfill all of the symptoms that we're seeing. And I like to open with that because, as we will discuss, psychosis in children in particular is rather rare. Yes, Dr. Udama, common things are more commonly. I love that. There's a lot of verbiage on this slide, but I do want to highlight just a couple of things about post-traumatic stress disorder and the diagnostic criteria. The first is it requires exposure to an actual or threatened death or violence or other criterion A event. And so the DSM classifies this as actual, witnessed, or learned about violence towards someone. It could be physical or sexual violence towards the patient that we're seeing, so the child in question. It could be witnessing violence between caregivers, between other adults. It could also be natural disasters, hurricanes, earthquakes, It could be war or other sorts of violence. It could be neglect, right? These are all things that kind of fall under, and then many more broadly. These are all things that kind of fall under that criterion A experience. And then when we are looking at that, we want to see if, as a consequence of exposure to this event or events, because people can have multiple, are we seeing at least one or more intrusive symptoms? And those are the things that people often think about when they think of PTSD, right? It could be flashbacks, it could be intense dreams or distressing memories. It's things that are kind of intruding into that person's conscious awareness. Are we seeing one or more avoidance symptoms? So is the person actively trying to avoid external cues, people who remind them of the perpetrator? Places that remind them of the criterion A event. For example, if it's a car accident, is a child or adolescent avoiding getting into cars or driving down the particular street on which this accident occurred? Or are they avoiding internal symptoms? So are they trying really hard not to think about or talk about the event? Are they trying to actively suppress memories or emotions or thoughts related to it? That's kind of what we think of generally when we think of avoidance. Are there two or more alterations in mood? So sometimes people don't realize that mood changes can happen as a result of PTSD. But what we start to see are persistent and exaggerated negative beliefs about the self. So it could be something like, I am a bad person. This happened to me because I deserved it. It can also be thoughts about others, like no one can be trusted, or the world, like the world is an unsafe place. So we can see these persistent changes in the way that people think that can also lead to changes in mood, right? Like depressed mood, irritability, suicidal ideation, even for folks, an inability to experience positive emotions as a result or as a consequence of this trauma exposure. And then we're also looking for two or more symptoms of hyperarousal. So these are also things that people tend to think of when they think of PTSD. It's that kind of head on a swivel, right? Maybe people are experiencing symptoms of panic, maybe even physiological symptoms, sweating, increased heart rate, panic attacks, all of those things. It could be feelings of depersonalization or derealization, right, that occur as a result. And do these symptoms last for at least 1 month? Do they cause a disturbance in functioning and related to stress? And then we would also want to specify if these are happening with those dissociative symptoms that I mentioned, or if there's a delayed expression. So the symptoms don't start right after the trauma exposure or exposures, but rather weeks or months kind of down the line, we start to see these symptoms. And so that's kind of what we think of PTSD for folks who are 6 and up. When we're looking at children who are 6 and under, that is going to be the column that y'all see on your right-hand side of the screen. And it looks a little bit different because kids who are under 6 have a harder time kind of conceptualizing and talking about, right, these particular things like thoughts or dissociation. They might have a harder time explaining it. So what we really look for in these children are one or more intrusive symptoms. That could be dreams, it could be nightmares, it could be flashbacks. They do not have to necessarily be distressing, and the content of the nightmares may not be clear. So if a child has experienced physical abuse, they may be experiencing really troubling nightmares as a result, but it is not necessary that they have to explain to you that the nightmares are about the instances of abuse that they experienced. They could be more broad than that. We want to see one or more avoidance or mood alteration symptoms in these children. Once again, the understanding of internal avoidance is a little bit harder to discern. So we're a little more focused on external avoidance. Are children avoiding certain people, places, things, situations, conversations? Are we noticing changes in behavior, like increasingly experiencing negative emotional states like, sadness, tears, fear, anxiety. Perhaps a child that was previously pretty happy-go-lucky and relaxed is no longer able to experience those same positive emotions. We might also see changes in social interaction. They might become more withdrawn, less social than they were with peers and or with adults. And they may be less interested in participating in activities that they once enjoyed or play with other children or with other adults. And then we also want to see 2 or more hyperarousal symptoms. For children under 6, we aren't expecting to see reckless behaviors, as an example, or self-destructive behaviors necessarily as a result of the trauma. And so these are some differences that we might expect to see in kids who are 6 or under. Similarly, you may notice that kids become, more distractible, more irritable, have a harder time concentrating. In some cases where there has been sexual trauma, guardians or parents may notice more sexual acting out on the part of these children. But the bar for meeting the PTSD criteria here is a little bit lower for 6 and under, as you may notice. When we turn to schizophrenia, however, what I want to point out is that we don't really have a change in diagnostic criteria for adults or children. This is kind of the diagnostic criteria that the DSM-5 has given us at this point in time. And what we see are that we need at least 2 of the following symptoms persisting for at least 1 month. And at least one of those symptoms has to be one of the bolded items on this slide. So hallucinations, that could be any form of hallucinations, auditory, visual, sensory, delusions, or, thinking, for example, like grandiosity or hyperreligiosity or paranoia, or disorganized speech. So those are kind of the big 3. We need to see at least one of those present for a duration of at least 1 month. The other 2 symptoms that we commonly see with schizophrenia are disorganized behaviors or catatonia, which can look different for different folks, and the negative symptoms. And when we speak about negative symptoms, we're really talking about a decrease in what we would consider normative functioning. So decreased speech, decreased affect, decreased engagement, decreased motivation, all of those things. And all of these symptoms need to be related to a significant impairment in functioning. We need to see these symptoms for at least 6 months. And we can see, we need at least 1 month of active symptoms. But if we have 6 months, negative symptoms kind of count within that broader range. And these symptoms are not caused by a substance, medication, or any other medical or psychiatric condition. So, if someone is experiencing these symptoms because they are actively using methamphetamines, you would want to consider as a substance-induced disorder, right? Or if this person were not to be on methamphetamines, would they be experiencing these same things or not? So those are kind of the really brief DSM criteria. As I mentioned for schizophrenia, we kind of break it down into these 2 symptom categories, positive and negative. That's not to say that some symptoms are better than others. But what it does mean is positive symptoms are generally conceptualized as an addition to baseline functioning. So that's those unusual feelings, behaviors, or thoughts, and kind of those categorize hallucinations, delusions. When we're thinking about negative symptoms, we're thinking about an absence or a decrease in normative function. And so that's that decrease in emotional expression, social activation, motivation, speech, all of those other criteria. So when I'm using the terms positive and negative symptoms throughout the rest of this presentation, kind of be thinking about these categories. So as a little poll for our audience, when we are thinking about childhood onset schizophrenia, what aspects of normative development do you think we should be taking into consideration before assigning this diagnosis? Based on what you know up until this point, or things that maybe you're just kind of thinking about? Are there aspects of normative development that we should take into consideration? Once again, you can put it in the chat. You can kind of speak up. Oh, thank you, Dr. Kerr. Yes, imaginary play versus true hallucinations. For those of you who work with children, have children, you probably know it's pretty normative for especially young kids to have imaginary friends or engage in imaginative play. that in and of itself is not sufficient for a diagnosis of schizophrenia, or we would have many, many kids diagnosed. Dr. Simmons, yes, cognitive functioning and developmental delays, excellent. So if we're working with kids who are on the spectrum or who have other developmental delays, particularly if we're thinking about speech or affective blunting, that may be best described by something like an autism spectrum disorder and not by something like a childhood onset schizophrenia. Excellent. Yes, Dr. Okpeki, I'm sorry if I didn't say your name correctly. Kids kind of struggle to properly articulate feelings and thoughts in childhood. And so if they're explaining things like hearing a voice, there is a possibility that they're describing their own sort of internal monologue. And I'll kind of walk you through later in the presentation some questions that we can ask to kind of help us get at if that's an experience that is occurring or not. Fantastic thoughts, everyone. We're going to skip the second question in the interest of time. So here's my next question. Some of those PTSD and schizophrenia diagnostic criteria can kind of sound like they overlap. My question is, which symptoms do you think might be most likely to be misinterpreted as psychotic symptoms when they're really representing a diagnosis of PTSD? Has anyone seen this happen in your own practice or have thoughts about which ones might be misdiagnosed? It's a quiet bunch today. Once again, you can, oh, Dr. Wu, excellent. Paranoia versus hypervigilance, feeling on edge. Yes, that someone is after them but can't describe. Excellent. So if a child has experienced trauma, right, it is natural that they might be feeling hypervigilant. That's a symptom of PTSD. And if we're not doing our due diligence, we can misdiagnose that as paranoia. Excellent example. Any others that you can think of? Auditory hallucinations versus an imaginary friend. Yes, certainly, Dr. Lopez. And I would even go so far as to add, sometimes children even will describe hearing the voice of their perpetrator, and it's more of a flashback, right, or a distressing memory rather than a true hallucination. Dr. Okpeki, paucity of emotions. Yes, excellent. Y'all are doing fabulously. Also, when we see dissociation in kids, right, or flashbacks, these are things that can also seem like psychotic symptoms if we're not doing our due diligence to rule out the contribution of trauma. So let's talk a little bit about why we're speaking about horses and zebras today. In schizophrenia, even among adults, the lifetime prevalence that we really see is about 0.3 to 0.7%. And that's globally. Even in the United States, we actually skew a little bit higher than the global average. So we tend to be a little closer to that 0.7%. Sometimes, depending on the study, closer to 1%. But even so, 1% of the adult population is not a large number of folks who really meet true criteria for organic psychosis. What we typically expect to see in folks is a late teens to early 20s onset in people who are assigned male at birth, and an onset in the early to mid 20s for people who are assigned female at birth. Any onset of psychotic symptoms prior to that is even more rare than that 0.3 to 0.7%. So that's kind of where the zebras come in, right? I guess if we were in another country, perhaps we need to use a different metaphor. But when we're thinking about working with kids and identifying these symptoms, we want to be sure that we're distinguishing from fantasy play, that we're considering neurodevelopmental concepts and diagnoses, and that we're also considering the impact of culture and trauma experiences that kids might have had. On the other side of that, the lifetime prevalence for post-traumatic stress disorder is 8.7%. So it is much more common. And historically, though it has not been as prevalent in younger children, the research really agrees that this is probably due to the lack of developmentally informed diagnostic criteria and low rates of screening. across settings for children. And that if we were to kind of modify those things, we would actually be seeing much higher rates of PTSD and trauma exposure in children. In children who meet diagnostic criteria for PTSD, we also see a lot of comorbid obsessive compulsive disorder and separation anxiety. And children who meet diagnostic criteria for PTSD are also at higher risk for long-term behavioral and emotional damage and poor outcomes throughout the lifespan, especially when that remains untreated. So, what is the relationship between trauma and psychosis? There are really three primary pathways that we think about. One is that experiencing trauma in childhood, particularly repeated instances of trauma, can increase a person's risk for later developing a psychotic disorder such as schizophrenia. The other is that having a psychotic disorder can increase someone's likelihood of being the victim of abuse and neglect and actually increase their risk for then developing PTSD. We know that folks with schizophrenia are actually at greater risk of being victims of violence than they are being perpetrators of violence. So it makes sense that if someone is unwell, if they are using other substances, maybe they're homeless, they're not in safe situations, that they're at increased risk for being traumatized. And the third relationship is that trauma and psychosis really influence each other and the development of both symptoms. And so these three possibilities are kind of what I want you to be thinking about with maybe some patients that you've seen in your own practice. Recent literature has also shown that about 75 to 98% of people with those disabling psychiatric conditions like schizophrenia endorsed experiencing traumatic events. Not just one, but multiple. And so I think that also should help us understand the importance of really screening for trauma exposure in children and adolescents, as well as in adults. And that experiencing 2 or more trauma events significantly predicted psychosis. And this was a large-scale study that was done on populations both in the United States and in the United Kingdom. Interestingly, in the US, childhood physical or sexual abuse trauma events were more likely to lead to the later development of psychotic symptoms, whereas in the UK sample, the trauma was different. So people were more likely to develop psychotic symptoms if they experienced serious injury or assault or violence in the home. Interesting kind of finding, unclear why. Research is still kind of being done into this. But we also know that experiencing trauma increases people's risk of suicide, both suicidal ideation and death by suicide. Earlier onset of serious mental illness symptoms. So even if someone has a biological vulnerability, experiencing trauma earlier in life can kind of trigger earlier than it might otherwise have been. Increases in symptom severity. So folks who meet criteria for both schizophrenia and PTSD typically have more severe symptoms and treatment is less effective, right? And they're a more complex case. So I want to kind of toss that out there. And then what we're all here for is when trauma looks like psychosis, what can we do? And how do we know how to kind of tease apart the relationship between the two? Well, my first argument is we have to screen for trauma. If we're not properly assessing trauma, we can confuse trauma symptoms versus psychotic symptoms. And several of you mentioned these earlier, right? Flashbacks, re-experiencing symptoms, dissociation, or things like paranoia or persecution. And we really want to be thinking, especially in today's climate, about the role of systemic and institutionalized oppression and trauma. One thing that we know from the literature is that patients who are Black or African American are at increased risk of being diagnosed with schizophrenia. They're also at increased risk of being prescribed antipsychotic medications when that might not be the most appropriate form of treatment. And we want to pay attention to cultural factors that are leading to that, because what we know is that schizophrenia does not actually occur more commonly in that population. It is misdiagnosed in that population. And there are some reasons for that. And some are multiple traumatic instances that people experience, including oppression, discrimination, and prejudice. as well as feeling uncomfortable in medical settings. So if a patient is uncomfortable being with a doctor, especially one of a different racial or ethnic background, they may make less eye contact. They may seem guarded. They may be hesitant, right? They may be unwilling to disclose certain things. And we need to be careful that we don't interpret that as psychosis and that we're really doing our due diligence culturally. And then the other thing that we want to consider is that childhood sexual abuse has been specifically linked to experiences of hallucinations and delusions later in development. And so if we're meeting with someone, we're thinking, oh, maybe this person is experiencing hallucinations, or we're even, it's on our radar that psychosis is a possibility. I would argue that we want to make sure that we're doing a trauma screen and that we're not missing trauma because we're becoming so focused on something that could be psychosis. May not be, but could be. And so we want to make sure that we're doing our due diligence screening, even if we think we hear something that sounds like hallucinations. So I know that we have a diverse range of providers here from different backgrounds, and just take a moment now if you'd like to speak up or put it in the chat. Which symptoms or presentations have you seen the most with children and adolescents in your own practice up until this point? If any. Any brave soul want to volunteer? Okay, what about this? What is your current practice for screening for trauma and psychosis with your child and adolescent patients? Feel free to drop it in the chat or raise your hand and speak out.
So David, again here at the BHC, we generally do basically a DSM-5 clinical diagnostic interview for PTSD with new patients. Like every visit, at minimum, depression, anxiety disorder screening, PTSD screening, psychosis screening, and then if appropriate, look at OCD or other things. But you ask about trauma every time.
Excellent. Thank you, Dr. Pollard. So in a behavioral health clinic, a specialty clinic, you're able to screen for that every time. That's fantastic. What about other folks who are in other settings like primary care or peds? Are you consistently screening for trauma, or what does your current practice generally look like? Or are we not screening for trauma at all? Many people don't. They don't have the opportunity. Okay, we're quiet. We'll come back to these. So for those of us who aren't currently screening, I listed a couple of accessible screens that are supported by the research. I do want to note that screeners are not diagnostic. So if we administer one or more of these measures and a kid kind of pops as being at risk or symptom levels are highly rated, what we don't want to do is say, okay, they definitely have PTSD. What we want to do is say, okay, this is really important information. I need to ask more about trauma exposure, and I need to refer to an appropriate specialist provider. Several of these, and I'll give you all a link as well with information and links to these. Several of these are freely available, but not all of them. So the child PTSD symptom scale is for kids ages 8 to 18. That one is free to administer. And the child stress disorders checklist screening form is for ages 2 to 18, and it is also free. And it is something that is actually completed by an observer. So you as a provider, it's just 4 items. You can observe and rate it. You can hand this to a parent or a guardian. You could send it to a teacher or a daycare worker or someone else who's with the child and have them actually rate the child. on these scores. That's why it goes down as low as 2. So that's pretty fantastic. The child trauma screening questionnaire is for kids ages 7 to 16, and it's also free. And then PTSD in preschool age children is also a measure that you can do for kids ages 2 to 5. And that one is actually completed by a caregiver. So you can give that to a parent or a guardian and have them complete it based on how their child is interacting and symptoms they might be experiencing. For adolescents, the UCLA is one that is commonly used. It has a lot of research backing. However, there is a cost involved for administering it. And that one's appropriate for school-aged kids and adolescents. Similarly, the trauma symptoms checklist for children is ages 8 to 16, and there is a cost involved in that one as well. And then the Children's Psychiatric Rating Scale and Brief Psychiatric Rating Scale for children are also both available at cost. So depending on what's reasonable for your clinic or what's feasible, I try to put up here some briefer measures, some of which that are free that you can hopefully have access to. Or if you're interested in sort of learning more about them, I've got a website at the end that discusses kind of the ins and outs of each of these measures. So you and your clinic manager or whoever can kind of sit down and decide what's right for your practice. What do we do when a kid screens positive for PTSD or trauma symptoms and we think, okay, this is something that could be going on? One thing that we want to note for children specifically, and when I say children here, I'm talking about kids 12 and under, is there isn't a lot of evidence to support psychopharmacological intervention for pediatric PTSD at this point in time. However, some folks do use an SSRI. And for psychosis, there really isn't a lot of literature to support medications for kids under 12 at this point in time either. And I would recommend, if medication is going to be something that you're thinking about for either psychosis or trauma, referring to a child psychiatrist. I know we also have our wonderful CPAN program that we're representing here. You can also give them a call and speak with a child psychiatrist and see if placing a referral for this kid in question would be helpful. The good news is, and sometimes folks aren't aware of this, we have several psychosocial interventions that are actually evidence-based and effective for kids, even under the age of 12, who have experienced trauma, whether or not they meet full diagnostic criteria for PTSD. And sort of the juggernaut, the biggest one is this TFCBT, or trauma-focused cognitive behavior therapy. This can be done with children and adolescents ages like, I think it's 3 to 22. So there's a really wide age range there. It has parental or caregiver involvement in the intervention, and it has age-appropriate accommodations. So if you're working with a child and a family and there's concern for PTSD or even just significant trauma symptoms, you can always put in a referral to a local psychologist or counselor who has training in TFCBT. For some kids, older kids, it doesn't skew as low. Folks have used EMDR and also psychoeducation. Similarly for psychosis, this one surprises a lot of people, but we do have evidence-based material for children and families. And it's primarily within that CBT family. So we can do CBT with kids and with parents or caregivers on sort of like parent management, behavioral management, and supportive work with their kids. Psychoeducation is a huge component. And then stress management work is also a big component. And family-focused work when we have psychosis on board. We also know that case management needs are really important, particularly for kids who legitimately meet criteria for childhood-onset schizophrenia, because their cases tend to be more severe and less treatment responsive. And so having case management involved to assist with appropriate academic accommodations and other kind of social programs can be very, very important and effective for these kids. And then what about adolescents? So adolescents generally, when we're thinking about that age group, it's 12 or 13 and up. Similarly, with pharmacotherapy, I would always refer for either trauma or psychosis to a child psychiatrist who has the training, simply because pharmacotherapy for trauma is not generally our first line treatment. And for children and adolescents, even though antipsychotics have been prescribed for adolescents, the research there is we don't have as much longitudinal work, and we don't know all of the risks and rewards. So I would really work with a child psychiatrist before prescribing an antipsychotic, although some that I have listed here have demonstrated evidence in children down to the age of 13, with the exception of paliperidone, which has been used in children as young as 12 with some benefit. So there are a few, generally more kind of second-gen antipsychotics, but would really recommend caution. What we do know about these medications is they come with high side effect load, especially when we're thinking about like metabolic load and things of that nature. So we really want to be working with children and families to manage their medications at as low a dose as possible. And then psychosocial interventions, same here. For our adolescents, TFCBT is great. And something like CPT or cognitive processing therapy can be done in children as young as 12, or I'm sorry, as young as 16, depending on the maturity of the child and the parental involvement. And for psychosis, we have a wonderful intervention also called CBT for psychosis that we can use with adolescents and families. This can be done with just an adolescent. It can be done with family involvement for kind of the greatest benefit, but it also teaches kids to identify like how they're thinking about things, to generate alternative explanations, and to develop effective coping skills for their symptoms of psychosis. Once again, supported employment and education programs are really important. One thing that we know about early onset schizophrenia is that it has a higher impact on folks because it interferes with their school years, right? And so people don't develop the social skills and the academic skills that they would otherwise have if their symptoms develop later. So supported employment, supported education, social skills training, groups, and individual work are all really important for helping these adolescents develop the skills they need to be successful later in life. And so these are also things that you can kind of talk with providers in your area about and see who offers these services as appropriate referrals. And then I included a couple of skills that I just wanted to spend, I realize we're kind of coming to the end of our time, but these are specific things that you can do quickly and briefly in an office visit to help manage stress. Whether someone is experiencing heightened anxiety as a result of trauma, whether they're experiencing a lot of stress and anxiety as a result of psychosis, or as a combination of the two, the skills that I'm about to show you can help across the board. So even if you're stumped, you're not sure, you're referring out for diagnostic clarity, but the kid and the family just need something to do right now, there are some very simple skills that you can use. One is called sensory grounding, and it's something that you can do that activates the person's 5 senses. We ask the kid to keep their eyes open as they move through this practice, and it helps them stay focused in the present moment. So if they are experiencing flashbacks or distressing memories or intrusive emotions, this can help ground them in the present moment, reduce those symptoms related to trauma. If they're experiencing a lot of anxiety related to psychotic symptoms, this is something that can actually help reduce that anxiety and keep them more in the present moment. And so you can walk people through, for example, there are many ways to do this, but one example is 5 things, asking the child to identify in the room, 5 things that they can see right here and now, 4 things that they can feel or touch right in the here and now, 3 things they can hear, 2 things they can smell, and 1 thing that they can taste. And so this is a simple skill that you can work through with your kids. Another great skill, and I've included a link to a great YouTube kind of resource. So if you'd like to watch it for yourself to sort of learn how to do deep breathing or recommend it to patients, this is one example. There are many online, but just some basic abdominal breathing. Once again, we know that trauma symptoms and psychotic symptoms are both increased by subjective stress. So if people are experiencing a lot of stress, anxiety, intrusive symptoms, or paranoia, whatever the case may be, teaching a deep abdominal breathing relaxation exercise can really help folks in the moment reduce symptoms and be more present with you in your work. And then the last one is a fun little game that comes from CBT for psychosis called Look, Point, Name. This is a visual grounding exercise that the person can play by themselves or with a partner. And it involves, once again, grounding yourself in the present moment by looking around the space that you're in, pointing at an object and saying its name out loud, and doing this until you exhaust your visual senses. So it could include like counting the number of ceiling tiles or noticing a scuff on the wall, or, you know, tiny little things, right? So garbage cans, door handles, blinds on the window, all different kinds of things that they can look, point, and name. And it's kind of like I Spy. And not only is it fun, I don't usually call it a skill when I teach it, I call it a game. And so people are sometimes a little bit more willing to play it. And I'll demonstrate by playing together. So we'll take turns naming different things that we can see in the room. And usually one thing that you'll notice is people actually start to smile a little bit. They start to enjoy it and their anxiety starts to decrease. So if they're disorganized from psychotic symptoms, they're organized enough to start to have at least a little bit more of a helpful conversation with you. If they're experiencing a lot of trauma symptoms, they're dissociating, they're experiencing flashbacks, it can really help ground them in the present moment. And so these are some just very basic skills that I would recommend sort of adding into your toolbox that you can use at this point, regardless of whether you know for a fact that it's a PTSD or a childhood onset schizophrenia. And then in our last few minutes, I just want to talk about some recommendations really quickly for practice. The first is screening for trauma exposure or symptoms and psychotic symptoms should be done routinely. If you're already doing this, fantastic. If you're not already doing it, think about working with the folks in your clinic to make this part of your routine practice. It can be giving a measure to, you know, an adolescent or a measure to a parent. It could also be as simple as asking some questions verbally, like, does your mind ever play tricks on you? Or do you ever hear noises or voices that other people can't hear? And then if they say yes, asking a little bit, what is that like? Do you recognize the voices? What do they say? Where do they come from? Questions like that to give us a better idea about etiology. And we also want to be screening for trauma. So if we're not doing that already, who takes care of you? You know, are you ever being left by yourself? How are you disciplined at home? You know, do your parents ever fight? If so, how do they fight? And do you ever see them? Has anyone ever touched you inappropriately? All these kinds of things that we need to be screening for. Otherwise, we can miss because people often don't just blurt out with trauma, right? And we have to actually ask the questions. And I do want to remember that screeners are not diagnostic tools. So just because someone says, yes, they hear voices, that doesn't mean that we're going to assign a diagnosis of schizophrenia. There are a lot of other things that we need to ask about first before we do that. Similarly, just because someone says they have experienced abuse or neglect doesn't necessarily mean they're going to meet criteria for PTSD. There's a lot that we need to do first, but screening is the first step, and it's a very important step that we need to be taking. So if someone does screen positive for trauma and or psychosis, consider what is developmentally and culturally appropriate or normative. So is this child at the age where having imaginary friends is normative? Do they have another medical or psychiatric condition that can better explain the symptoms that they're experiencing? Are they in a system where, you know, they don't feel comfortable with medical providers, and that could explain some of the hesitancy or guardedness or lack of eye contact that you see? Or, for example, is their cultural background one where making eye contact is inappropriate or disrespectful? Those are things that we want to consider. Yes, certainly. And Dr. Johnson also said for people who are in the foster care system or living with other caregivers, yes, so we should always be asking guardians. And as we sort of said, those parent report screeners don't have to be given to biological parents. They can be given to grandparents, foster parents, guardians, whoever is with the child. And many of those adult report measures can also be given to teachers, daycare workers, things like that, who interact with the children frequently. So you're getting a better picture. Excellent, Dr. Johnson. We also want to screen for suicidal ideation and self-harm. Even in kids, if they're endorsing exposure to trauma, if they're endorsing things that might be psychotic symptoms, we know that both those populations are at increased risk for suicidal ideation and death by suicide and making suicide attempts. So we need to be screening. We need to be asking about it. And if they are saying, yes, they're having those thoughts, we need to be safety planning appropriately with the child and with the guardian, or considering hospitalization if that's appropriate. And we also need to be screening for substance use because we know both of these populations are at increased risk for substance use as well. And so if someone is saying, yeah, I hear voices, yes, I feel paranoid, and then you find out that they're smoking weed every day or they're using meth, that's also something that's really diagnostically important for us to know. So these are all things that we need to be screening for consistently with our kids and adolescents. And then I would also just encourage having folks in your community who are qualified mental health professionals that you know you can refer out to for a solid comprehensive diagnostic eval. So if you're in primary care, if you're in peds and you do the screenings, excellent. Who can you then collaborate with to say, I've got this patient that I'm concerned about, can we get them in with you for a comprehensive evaluation? And we also want to do our due diligence to do a medical workup to rule out any other medical or substance-induced symptoms. So, if we're seeing a kid who's really depressed and really fatigued, we want to make sure that we're getting their thyroid levels checked, right? There are things that we want to be doing rather than just jumping to the assumption of a psychiatric disorder. And my last note here is just don't wait for things to get worse. Early intervention is best, whether it's trauma or schizophrenia, right? If we are just sort of taking that watchful waiting stance, things can get worse pretty quickly and also can do some permanent damage to the kids' social development, academic development, all of the above. And so if we have concerns, we want to make sure that we're referring them to the appropriate providers and we're taking action early so that the child, the family, anyone who is involved with the child can begin taking the steps that they need to so that the child is able to be as successful and as functional as possible, because I think that's what we all want. And then for providers, my recommendations are this. Engage in professional development and consultation with people who have expertise in this area. If you don't have a lot of experience with PTSD, psychosis, or both, but this is something that you've been seeing in your practice, or you've had a couple of clients and you haven't felt as prepared, reach out, right, to providers in your area for consultation. Attend continuing education courses like this one today or others that are specific to your specialty. Engage in your own self-reflection and self-management techniques. A lot of providers say that they feel anxious themselves asking about trauma, asking about suicidal ideation, asking about psychosis. If that's you, that's okay. What we want to do is make sure that we are managing our own anxiety so that we can provide the best care to our patients. And we're asking the questions in a sensitive and appropriate manner, even if we feel a little anxious about it. Sometimes also a lot of folks hear something that sounds like a psychotic symptom or is a psychotic symptom, like a hallucination or a delusional thought. And then they get really worried and really afraid. And they're like, this person needs to be hospitalized. We need to do this right away. And it's understandable because sometimes people don't have a lot of exposure to that. Once again, self-management techniques are really important here because we want to manage our own response so that we're not scaring the patient, we're not scaring the family. We're able to approach this respectfully and openly and in an evidence-based fashion. One last thing is don't just for confirmatory evidence, we want to consider the whole clinical picture. So rather than just saying like, oh, they're endorsing voices, they must have schizophrenia, even if they're 10 years old, we want to do our due diligence that we're asking about family history, we're asking about substance use, we're asking about cultural factors. We're doing all of this work rather than just jumping to that conclusion and then saying, well, then all of these other things make sense. We want to really get a thorough picture. This National Child Traumatic Stress Network, the nctsn.org, this is a great website for all kinds of providers who are working with children who have experienced trauma. They have a whole section on assessment. So if you don't have a trauma screener and you want to kind of go online and look at this website about what they have, that is a fantastic resource. You can see what fits best with your practice as far as like cost, population, like age range served, all of those things. Length of measure, there are some that are quite brief and some that are quite lengthy. You can also contact your local CPAN resource. So if you are in our region, our CPAN is the one that you would reach out to, but there are others across the state as well. So if you don't know your region, you can always contact us, and we can also help get you in touch with other CPAN providers. And then I always like to include the National Suicide Prevention Lifeline. They have a website, they have a phone line, they have a text line. This is a fantastic resource to have on hand to provide patients and families. SMIadvisor.org also has some really great webinars that are, many of them are free for providers. So you can log in and you can watch an hour-long webinar on trauma, or on childhood onset psychosis, or on medication to use with psychosis. So if you're looking for CEs and you're not really sure how to do that professional development piece, SMIadvisor.org could be a great place to start. And then the last two here are phone apps that I recommend to a lot of patients, that they can use to kind of reduce suicidal ideation and help them stay safe. So these are things that I would recommend kind of looking through for yourself to see how it best fits you, and thinking about kind of putting on a card or having in a resource that you can provide to patients after screenings. Here are the references that I used today. And I realize we're towards the end of our time, so I appreciate everyone this afternoon. And I did want to leave a few moments for questions or comments from any attendees. I thank you all so much for being here.
Thank you, Dr. Ross. I am going to go ahead and show the QR code for those that have to get to clinic here, but I really, really welcome questions. This is a really important topic. And having an expert, well as some of even our psychiatrists that are on the call today to answer questions. So please feel free to open up your mics and ask those questions or put them in the chat. We have a quiet group today.
I know. I would say my email was also on that last slide. So if anything comes to you, you know, feel free to send me an email or to send Laura an email, and she can direct any questions, comments, or concerns that you have to me, if that would be helpful.
I did put a note in the chat for the group here that if you are a PCP here in Texas, we can certainly provide you with a screener for trauma. There's one that Dr. Johnson has provided to us. And Dr. Johnson, the name is escaping me.
The Pearls.
The Pearls. And how is that different than some that Dr. Ross Young was sharing during her explanation of screeners?
That screen is a screen for trauma. So a lot of people are aware of the ACEs screeners, or the Adverse Childhood Experiences screeners, and that's technically for adults, but some people had been using them for kids. So basically the Pearls is the kids version that's validated for use in children. So it's just a screening tool as far as if providers need help with what questions to ask regarding trauma exposure, then you would use the Pearl. So that is that's when that would come into play.
Okay, great. And what age? I recently had a provider ask me what age is that validated for the Pearls?
Well, because there's a parent one for children, but I can't remember the lowest age for the Pearls right now. It's escaping me right now. And then there's a self-report for teenagers. And then I believe there's a parent one for teenagers too, but I can't remember what the youngest. Okay. I know it goes. I know I want to say 3, but I feel like that's what's sticking in my head, but I don't want to be wrong and say the wrong age because I cannot think right now. But for
Okay.
some reason, 3 years old is sticking out in my head.
You know, it's funny you said that because I wanted to say that that's what you had told me originally, but it wasn't on the screener itself. So I was following up. What other questions from our group here?
Well, and that's what I wanted to add to when I made the comment that and Dr. Ross Young spoke on the comment that I made about making sure to screen for kids who are in foster care, because or who are being taken care of, people who their parents are not their primary caregiver, because there's been plenty of times where I've gotten CPAN calls from providers who are telling me about a kid who's having, out of control acting out behaviors or what have you, and they tell me that they're in the foster care system or this or that, or grandmother's taking care of them or something like that. And then I would ask, well, have you asked about a trauma history? And they'll say, well, no. And so for me, it's kind of as soon as I hear that a kid is in foster care or that a kid is being taken care of by another family member, I immediately go into asking about trauma, because what are the circumstances that led that child to be in the foster care system or being, cared for by another family member? Something had to have happened, and more than likely it's probably trauma in order for that situation to have occurred. And so I feel that I've come across a lot of primary care providers forget to ask those questions in cases where there are, it's a clear something has happened because these children are not living with their parents.
Something that I have learned from the psychiatrists in working with them is that, and correct me if I'm wrong here, that ADHD, that trauma can actually look like ADHD sometimes.
Yes,
Yes.
It does. It looks a lot like it.
So explain that, if you would, a little bit.
Well, especially in younger children, one thing that we want to be thinking about developmentally is just, when did the symptoms start? So if the child wasn't acting out, wasn't irritable, wasn't distractible until a trauma or traumas happened, I would be less likely to diagnose that child with ADHD and consider more the impact the trauma has had. And Dr. Johnson, you can also speak more to this as well from your experience. Whereas if someone can demonstrate that even if a trauma has happened, but prior to that, this child was endorsing and experiencing behaviors consistent with ADHD, that would be a little bit different. That's kind of my experience with it.
Okay, great.
The timeline is important.
Interesting. And I see a note here from Dr. Kerr that if you're hypervigilant because of PTSD, it can look like difficulty focusing. I can see that makes sense, because you're focusing on everything in your environment. Yeah, go ahead, Dr. Johnson.
I'm sorry. I actually have a picture that I usually show, like literally I pull up on my screen when patients are in the office to show the overlap and the difference. It's like a Venn diagram of the overlap of trauma symptoms and ADHD symptoms. And then, on either side, it has more specific to ADHD or trauma, depending on which side you're looking at. I was trying to post it in the chat, but I'm not that technologically savvy, so I don't know how to do that. But yeah, I have a whole picture that I found online that kind of explains that. But the overlap basically is difficulty concentrating or learning, being easily distracted, doesn't seem to listen. So defiance, disorganization, hyperactivity, restlessness, and difficulty sleeping are the overlaps between the two. So you have to tease things out. And like Dr. Ross Young said, the timeline is very, very important and very helpful with teasing that out.
Great. Well, we are actually after the top of the hour. Dr. Ross Young, this was an excellent presentation. Thank you so much. We are excited to be able